Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. Today's episode is entitled Recurrence Rate of Cystoid Macular Edema with Topical Dorzolamide Treatment and Its Risk Factors in Retinitis Pigmentosa. I'd like to thank our host, Gretchyn Bailey, our topical editor, Dr. Andrew Rixon, and our topical expert, Dr. Jessica Haynes. And now it's my pleasure to begin today's broadcast.
Hi, everyone. I am Gretchyn Bailey, and I am a fellow with the American Academy of Optometry. And I am joined today by Jessica Haynes, who is also a fellow of the Academy. She is consulting faculty at Southern College of Optometry, as well as part of the Charles Retina Institute in Memphis. Jessica, thanks so much for talking with me today.
Awesome. Thanks, Gretchyn.
So today we are looking at a study, and the title of the study is Recurrence Rate of Cystoid Macular Edema with Topical Dorzolamide Treatment and Its Risk Factors in Retinitis Pigmentosa. And this study was conducted by Shimokawa and colleagues, and the results appeared in the January 2022 issue of the journal Retina. This retrospective study looked at the rate of recurrent CME secondary to RP. And ODs have long been told that dorzolamide is effective in treating CME in patients with RP. Do the study results bear this out?
So I was very interested to see the results of this study myself, because whenever you have a patient with RP, they present with CME. It's such an easy sort of go-to thing to put them on a topical carbonic anhydrase inhibitor, such as dorzolamide. It's something that's readily available, low risk. Optometrists can easily do that. But a lot of these patients did have recurrence of CME 1 year, 3 years, 5 years, even whenever they continued treatment. So essentially what this study looked at is patients who had cystoid macular edema and were put on topical dorzolamide. Those that had resolution or more than 20% reduction in their central subfield threshold were included. And then they kept the patient on the topical CAI. They were using it 3 times a day, and they saw how many of those patients, even when they were kept on treatment, had recurrence of the disease or recurrence of the cystoid macular edema. And at 5 years' time, it was about 50%. So that's pretty significant.
Mm-hmm. Well, should these results affect optometrist clinical care for patients with retinitis pigmentosa?
So they really should, because when you have a patient and you use any type of treatment and you see positive results, there's sort of this feeling of, okay, maybe I don't have to follow the patient as closely. I won't see them as often. But knowing that even though you get that initial response, there's still this potential for the CME to come back or for your treatment to sort of lessen over the course of time. So you still have to monitor these patients.
So if you had to summarize this study in one key point for optometrists, what would it be?
It would be that if you have a patient with CME who has retinitis pigmentosa and you put them on a topical CAI, even if they respond to treatment, continue to monitor the patient. And if the treatment ultimately fails, sometimes you do have to consider some of these other options, such as oral CAIs, intravitreal steroids, intravitreal anti-VEGF, etc. So do be cautious in these patients and do keep a close watch on them.
Good advice. Thanks so much for talking with me today, Jessica.
Thank you.
And a special thanks to CooperVision for their educational grant to make it all happen.